So now let's talk about oral medications that we use to treat diabetes. Our first one is metformin, which is a big one-eyed. Metformin is historically first line for type 2 diabetes, and it can be used in patients without islet dysfunction. It can also be used in patients who are pre-diabetic, which means that their A1C is between 5.7 and 6.4, to prevent them from fully developing diabetes. The way metformin works is that it decreases hepatic gluconeogenesis. It increases glycolysis. So gluconeogenesis is going down, glycolysis is going up, and increases glucose uptake in muscle and fat along with insulin sensitivity. So three things go up and one thing goes down. Hepatic gluconeogenesis goes down, glycolysis goes up, glucose uptake in fat and muscle goes up, and insulin sensitivity goes up. It will also reduce plasma glucagon levels. Interestingly enough, they will decrease endogenous production of insulin because the body will not need to make as much to achieve the desired glycemic control. And this will prevent beta islet cell burnout. And remember that anytime endogenous insulin goes down, C-peptide levels go down, and if endogenous insulin goes up, C-peptide levels go up. They like to ask you about that. So if endogenous insulin goes down, C-peptide goes down. If endogenous insulin goes up, C-peptide goes up. Side effects of metformin include GI upset. Keep in mind that metformin will not cause hypoglycemia compared to other oral drugs. It can and will decrease folate and vitamin B12 absorption. It can also cause potentially fatal lactic acidosis in patients who have underlying renal and liver disease, so make sure you look at the labs in the question stem to see if the patient has elevated liver function tests and or creatinine. Welcome back to the Pharm Professor. Let's talk about renal pharmacology. We're going to be talking about diuretics. Here's a beautiful diagram of where diuretics work in that nephron loop. Now, we're not going to get into the physio of the nephron, but we are going to talk about the mechanism of action, and this diagram will be a great one for you to refer to as we review these drugs. All right, so the first drug we're going to talk about today is mannitol. Mannitol is an osmotic diuretic. We use it for elevated intracranial pressure, elevated intraocular pressure, as well as for drug overdose. The way it works is it increases the renal tubular fluid osmolarity, which then leads to an increased urine flow. You see a nice little diagram here, and as you can see, mannitol will not be reabsorbed in the nephron. That allows it to exert an osmotic force upon the free water in the kidney. Water will follow the solute. As a result, mannitol will pull water from within the renal parenchyma into the tubular fluid to be excreted. So as you excrete that fluid, your volume becomes reduced. Side effects of these medications include pulmonary edema and dehydration, exacerbation of heart failure, and hypo and hypernatremia. Now keep in mind that as we discuss diuretics, you're always going to see dehydration as a side effect. You're also going to see electrolyte disturbances, and those will depend on where these diuretics are working in the nephron. So for mannitol, you want to keep in mind that you can have hypo or hypernatremia, which makes sense because sodium and water tend to work with each other. Nursing considerations before you administer the drug: assess their neurological status. By that I mean headache, intracranial pressure, and changes in their mental status. Assess their intraocular pressure, their pupil size, their vision, and make sure that they are well hydrated. Let's talk now about carbonic anhydrase inhibitors. We have acetazolamide and dorzolamide, and as you can see, they both end in lamide, L-A-M-I-D-E. That's a pattern you want to keep in mind for carbonic anhydrase inhibitors. What do we use these drugs for? We use it to alkalize urine, metabolic alkalosis, and acute mountain sickness or altitude sickness. Now, these drugs will generally be taken a couple of days before someone travels to combat the respiratory alkalosis that happens in response to high altitude. It can also be used to treat pseudotumor cerebri and glaucoma. The mechanism of action, we already said that it is a carbonic anhydrase inhibitor. It inhibits carbonic anhydrase. And as a result of that, you have decreased aqueous humor synthesis, which is why it's helpful in pseudotumor cerebri and glaucoma. It decreases the sodium hydrogen exchanger, and you can see that picture there. And as a result of the inhibition, there is more sodium, more chloride, and more bicarb left in the tubular fluid. Now let's talk about anticoagulant medications. This image shows you where anticoagulants work in the coagulation cascade. We'll talk about all of them individually, but this is a nice image to put everything together. Let's begin by talking about heparin. So one thing I want you to know and keep in mind is a pattern. We're going to go back to the alphabet. Heparin and warfarin. H comes first, W comes later. Heparin is used for acute conditions, warfarin is used for chronic conditions. Heparin has a short half-life, warfarin has a long half-life. Let's talk about heparin. Heparin is used for immediate anticoagulation for pulmonary embolism, acute coronary syndrome, MI, as well as after cardiovascular surgery. We can also use it for DVT and disseminated intravascular coagulation, or DIC, and we can also use it in anticoagulation during pregnancy because it does not cross the placenta. The mechanism of heparin is that it binds to antithrombin 3 by acting as a cofactor. It will decrease thrombin and formation of factor 10A. I told you it has a short half-life. Its short half-life is in fact 2 hours, so it can be stopped the same day of surgery. It's easily reversible if toxicity develops and heparin overdose is treated with protamine sulfate. Remember that. So once again, heparin toxicity is reversible and treated with protamine sulfate. Side effects, you can have increased bleeding. If you have increased bleeding, you're going to administer protamine sulfate. Another side effect is osteoporosis and heparin-induced thrombocytopenia, or HIT. It can also cause heparin-induced thrombocytopenia, or HIT, and we're going to talk about this more a little bit later. IgG antibody is formed against heparin and the PF4 complex, which will then lead to the consumption of platelets as well as arterial and venous thrombosis. This will be presented in a question stem as a patient who was started on heparin, who experiences a drop in platelets of 50% from baseline within 5 to 7 days of being started on heparin. The way you treat it is you discontinue the heparin. Nursing considerations: before you administer the drug, perform coagulation studies and measure hematocrit, hemoglobin, red blood cells, and platelet count. During and afterwards, continue lab studies at regular intervals throughout therapy. Monitor activated partial thromboplastin time, or APTT, and adjust the dosage to keep APTT at 1.5 to 2.5 times normal. Monitor the vital signs and monitor needle sites daily for hematoma and inflammation. Report fever, drop in blood pressure, rapid pulse, or hemorrhage. Risk of hemorrhage is greatest in women, in patients above 60, in patients with liver or renal disease. Now let's talk about warfarin. I already told you warfarin is used for chronic conditions and has a long half-life. We use it for long-term anticoagulation. We use it for valvular AFib, and that's if AFib is caused by mitral stenosis, mitral regurgitation, or any other left-sided valvular issue, we must use warfarin. The novel oral anticoagulants are not approved for anticoagulation in valvular AFib. We can also use it for prophylaxis for DVT and PE. The mechanism of warfarin is that it inhibits vitamin K epoxide reductase, which then decreases gamma carboxylation of vitamin K dependent clotting factors. What factors are they? 2, 7, 9, 10, protein C and S. 2, 7, 9, 10, C and S. Factor 2, factor 7, factor 9, factor 10, protein C and protein S. These drugs act on the extrinsic pathway, therefore they will increase the PT, they have a long half-life and a slow rate of onset, which is why it needs to be bridged with heparin initially. Warfarin also inhibits synthesis of new clotting factors, but does not affect clotting factors that are already formed. Class 1 antiarrhythmics are sodium channel blockers. There's class 1A, 1B, and 1C. 1A, these are moderate sodium channel blockers. Class 1B, these are weak sodium channel blockers. And class 1C, these are strong sodium channel blockers. Class 2, these are beta receptor blockers. Class 3, these are potassium channel blockers. And class 4, these are calcium channel blockers. We're going to go over all of these individually, so don't worry. Let's begin by talking about class 1. Like I said, class 1 antiarrhythmics, these are sodium channel blockers. And you can see the effects of class 1 antiarrhythmics on the ventricular action potential in this figure. Class 1A. I like to use mnemonics to help remember these drugs because there are so many of them. I like to think about antiarrhythmics reminds me of rhythm, which reminds me of music, so my mnemonics here are related to music. So class 1A, my mnemonic here is ABBA. Remember the group ABBA, they performed that song Dancing Queen? So the mnemonic is ABBA performed Dancing Queen. A for ABBA, class 1A, performed Dancing Queen for PDQ, procanamide, disopyramide, and quinidine. Okay, ABBA performed Dancing Queen, PDQ, procanamide, disopyramide, and quinidine. Class 1A antiarrhythmics like procanamide, disopyramide, and quinidine will increase the action potential duration. They will increase the ERP and increase the QT interval. Once again, these drugs will increase the action potential duration. They will increase the ERP and increase the QT interval. So let's talk about these drugs. The first drug is disopyramide. Disopyramide is used for atrial and ventricular arrhythmias. It's also used for reentrant and ectopic supraventricular tachycardia, or SVT, as well as ventricular tachycardia. We also use it for vagally mediated atrial fibrillation, but it's not first line. We only use class 1A antiarrhythmics like disopyramide for vagally mediated AFib if amiodarone and sotalol fail. Once again, only if amiodarone and sotalol fail. How do these class 1A antiarrhythmics work? I told you they are moderate sodium channel blockers. They block fast sodium channels, which then decreases the fast inward depolarization of cardiac myocytes. They decrease myocardial excitability and conduction velocity, which then will terminate those tachyarrhythmias. Side effects of disopyramide include exacerbation of congestive heart failure, so you avoid it in patients that have New York Heart Association class 3 and 4 disease. It can also cause torsade de pont due to the QT interval prolongation. And anytime you see the QT interval being prolonged, this is going to be a side effect that can occur. Nursing considerations: prior to administering the drug, assess their apical pulse and blood pressure, obtain a baseline ECG, and obtain baseline labs to assess liver and kidney function. While they're on the drug, monitor their vital signs, and after administration of the drug, monitor for renal function, for weight, and assess for signs and symptoms of congestive heart failure. Now we have procanamide. Procanamide is used for atrial and ventricular arrhythmias, reentrant and ectopic SVT and VT, very similar to disopyramide. They work the exact same way, but we're going to mention it again because I want you to know it and know it well. It will block the fast sodium channel, which will then decrease the fast inward depolarization of cardiac myocytes. It'll decrease myocardial excitability and conduction velocity, which will help terminate these tachyarrhythmias. Side effects of procanamide are a little different, and the one that I'd like to ask you about is reversible systemic lupus-like syndrome, okay? So reversible SLE-like syndrome. It can also cause torsade de pont, and if you see that, it'll actually show an EKG with polymorphic QRS complexes, no P waves, and tachycardia or a BPM above 120. Now, patients with underlying hyperkalemia are at increased risk of developing the arrhythmia associated with this drug. And that's because anytime you have more potassium, you have an increased risk of prolonging that QT interval. Nursing considerations for procainamide, once again, prior to administration, just like with disopyramide, you're going to assess apical pulse and blood pressure, obtain a baseline ECG, and obtain baseline labs to assess for liver and kidney function. During drug administration, you're going to monitor their blood pressure, their QRS duration, and QT interval. If it's given intravenously, you're going to monitor their BP every 5 to 15 minutes. And after drug administration, you're going to monitor their blood pressure and heart rhythm and assess them for signs and symptoms of thromboembolism. Class 2 antiarrhythmics, these are your beta blockers. There's a nice little image here that shows you the effect of class 2 antiarrhythmics on the ventricular action potential. Now, class 2 antiarrhythmics, like I said, are beta blockers, and they will decrease SA and AV nodal activity by decreasing cyclic AMP and calcium currents. So they'll decrease SA and AV nodal activity by decreasing cyclic AMP and calcium currents. This will decrease the slope of phase 4 and increase the PR interval. Once again, it will decrease the slope of phase 4 and increase the PR interval. We talked about these drugs already in the autonomic nervous system lecture. The beta blockers here are albuterol, carvedilol, esmolol, labetalol, metoprolol, and timolol. So let's talk about these drugs and their specific actions. Esmolol and metoprolol are beta-1 selective receptor antagonists. Esmolol is very short acting, so it's never going to be the right answer if they ask you for maintenance therapy. Albuterol is a beta-2 selective receptor antagonist. It can cause beta-2 induced bronchoconstriction in asthmatics, so watch out for patients that have asthma. They like to test you. Timolol is a non-selective beta receptor antagonist. Once again, there's a nice little image here. Carvedilol and labetalol are non-selective alpha and beta receptor antagonists. What do we use these drugs for? We use it for SVT, for AFib and aflutter, for hypertension as well. Propranolol is also given to people who have stage fright. Post-MI patients can be started on metoprolol to help reduce the myocardial oxygen demand, and carvedilol can be used in the setting of congestive heart failure to reduce mortality. The mechanism, once again, is it decreases the slope of phase 4. Now, with beta blockers, I'd like to ask you what goes up and what goes down. What goes up and what goes down? Well, 3 things go up: end diastolic volume, ejection time, and PR interval. EDV, ejection time, and PR interval. The end diastolic volume, because the cardiac cycle will slow over time, you'll have slower contraction and heart rate, which means you will have more time to fill in diastole, leading to an increase in your end diastolic volume. You will have an increased ejection time, and your PR interval will be increased. And remember, your PR interval is the time from atrial contraction and initiation of ventricular contraction. What decreases? Production of cyclic AMP decreases, which means the beta receptors that are GS coupled will have decreased adenylate cyclase activity, which means they will have slower intracellular signaling. This action is really relatively specific to the AV node, which will reflect as that prolonged PR interval. You will have a decrease in calcium currents, you will have a decrease in blood pressure, and you will have a decrease in contractility. That means it is a negative inotrope. They like to ask you about that. So what are you decreasing? You're decreasing cyclic AMP, you're decreasing calcium currents, you're decreasing blood pressure, you're decreasing contractility, and that is what we call a negative ionotropic effect. We also have a negative chronotropic effect because it will also decrease heart rate. It will also decrease myocardial oxygen consumption. By decreasing heart rate and contractility, you are decreasing the amount of energy the heart needs to produce for each contraction. This is the basis of beta blocker use in patients with heart failure. Side effects include exacerbation of COPD and asthma, bradycardia, AV block and sexual dysfunction. Treatment for overdose of beta blockers will be normal saline. If they're bradycardic, you'll give them atropine, and you can also give them glucagon. Nursing considerations: assess the patient for a history of heart disease and diabetes or pregnancy. Educate the patient to not abruptly stop taking the drug. It must be tapered gradually over a 2-week period. Inform the patient to report any symptoms such as swelling or difficulty breathing or depression. Monitor the patient for fever or slow pulse. Class 3 antiarrhythmics, these are your potassium channel blockers. Now this figure here shows you the effects of class 3 antiarrhythmics on the ventricular action potential. Class 3 antiarrhythmics, these potassium channel blockers, will increase the action potential duration, increase the ERP, and increase the QT interval. Once again, they will increase the action potential duration, they will increase the ERP, and increase the QT interval. Our first drug here is amiodarone, and amiodarone is used for AFib and aflutter, and also for ventricular tachycardias. How does it work? Well, it prolongs phase 3 repolarization, which means it's going to block then that potassium efflux. Like I said, it increases the duration of the action potential, and it increases your ERP, which then reduces responsiveness to atrial tachycardia. It also will prolong your QT interval. Amiodarone is the only drug in this category that does not have a risk of torsade de pont, and that once again is twisting of the spikes. Side effects. Well, if you look at the name of the drug, it has iodo in the middle of it. That's like iodine. That's why you can have hypo or hyperthyroidism as a result of iodine being a component of amiodarone's chemical structure. So you can be hypothyroid or hyperthyroid. You can also have pulmonary fibrosis, and that is very common with prolonged amiodarone use. In the question, look for a patient with a history of arrhythmia treated with amiodarone that presents with progressively worsening shortness of breath and a restrictive pattern on pulmonary function tests. It could also cause hepatic necrosis. So far, amiodarone is causing hypo or hyperthyroidism, pulmonary fibrosis, and now hepatic necrosis. It can also cause corneal clouding. Some additional side effects: it can lead to bradycardia and photodermatitis. It can cause constipation and heart block or failure. It does block CP450, so it will increase levels of wet PD, warfarin, estrogen, theophylline, phenytoin, and digoxin. Let's talk about acid suppression therapy. You have a nice little diagram here of where these medications work. It's a nice way to review once you've gone through that lecture. Our first topic is antacids. We have 3 drugs in this category. We have aluminum hydroxide, calcium carbonate, and magnesium hydroxide. All of these antacids decrease the production of stomach acid, and they do that by altering the gastric and or urinary pH and or delaying gastric emptying. They affect absorption and bioavailability of other drugs. They can lead to hypokalemia. Some specific side effects you should know: aluminum hydroxide has a strong constipation effect and can cause hypophosphatemia. It can also cause seizures and osteodystrophy, as well as proximal muscle weakness. Calcium carbonate can cause hypercalcemia. It's absorbed by the gut, unlike magnesium and aluminum, which stay in the gut. Magnesium hydroxide is known to cause diarrhea because it has a strong laxative effect. Remember, milk of magnesia you take when you're constipated. Magnesium hydroxide can also cause hyporeflexia because it beats sodium to that receptor site. It can also lead to cardiac arrest and hypotension. Nursing considerations: educate the patient to offset taking other medications for 1 hour before and 1 hour after taking these medications, because antacids can oftentimes affect the absorption of other medications. Now we're going to talk about H2 or histamine 2 antagonists. If you look here, they all end in dine: cimetidine, famotidine, nizitidine, and ranitidine. D-I-N-E. We use these for peptic ulcer disease, for gastritis, and for GERD. These work by reversibly blocking that H2 receptor, which then decreases the hydrogen secretion by parietal cells. This will inhibit, and by that I mean directly inhibit, acid production. Keep in mind that it works especially better at night. Side effects of some of these drugs: cimetidine with a C can cross the blood-brain barrier and lead to confusion, dizziness, and headache. Cimetidine with a C can also cross the placenta. Cimetidine with a C inhibits cytochrome P450 and has anti-adrenergic effects like gynecomastia, impotence, and prolactin release. C and R, cimetidine and ranitidine. C and R, you spell creatinine with C and R. Cimetidine and ranitidine both decrease renal excretion of creatinine. Nursing considerations with these drugs that end in D-I-N-E: educate the patient to take these medications 30 minutes before a meal, 30 minutes before you dine, D-I-N-E. Educate the patient that these drugs will increase the risk of bacterial colonization in the stomach. Now let's talk about PPIs or proton pump inhibitors. All of these drugs end in prazole, P-R-A-Z-O-L-E, all right? We use these for peptic ulcer disease, for gastritis, for GERD, for gastrinoma or Zollinger-Ellison syndrome, for prophylaxis of stress ulcers. And it's also part of a regimen for treating H. pylori. Look at what all of these conditions, other than H. pylori, have in common. They all have increased acid. That's why we inhibit that proton pump. Okay? How do they work? They irreversibly block the hydrogen potassium ATPase in parietal cells. These are lipophilic and weak bases. They become protonated and then concentrated, and when they become so concentrated, they will actually then irreversibly block that pump in these parietal cells. These drugs take a few days to take effect, about 3 or 4 days, but they are more effective than H2 antagonists. Side effects of these medications, and the one they love to ask you about, is Clostridium difficile infection. They can also precipitate pneumonia as well as hip fractures, and they can precipitate hip fractures because they inhibit calcium absorption, leading to a negative calcium balance, which will eventually lead to increased bone loss and increased fractures. As a result, you'll have decreased serum magnesium and calcium absorption. These drugs will also cause malabsorption of vitamin B12. They can cause acute interstitial nephritis as well. These drugs can also decrease the availability of drugs that require acidity, and one of these drugs is digoxin. So keep in mind that if you're dealing with a patient that is on digoxin, you'll want to avoid PPIs. Chronic use can lead to hypergastronemia, and the main symptoms of that will be abdominal pain, chronic diarrhea, and pancreatic tumors, which can either be cancerous or non-cancerous, ulcers, as well as severe esophagitis. Welcome back to the Pharm Professor. Let's talk about the parasympathetic nervous system. We said that the parasympathetic nervous system is responsible for rest and digest, which is the opposite of the sympathetic nervous system, which is responsible for fight or flight. Now, don't confuse the parasympathetic nervous system with the peripheral nervous system, because they both have that PNS 3-letter symbol. Now, you can see here in a little image, acetylcholine is synthesized from choline and acetyl-CoA in the presynaptic neuron. Upon the influx of calcium, acetylcholine is then released from the presynaptic neuron into the synaptic cleft, where it binds to corresponding acetylcholine receptors on the postsynaptic neuron. Now, drugs work on receptors, And most of the receptors in the parasympathetic nervous system are muscarinic receptors. Most of the receptors in the parasympathetic nervous system are muscarinic receptors. Muscarinic starts with an M. These are your M receptors, your M1, your M2, M3. But let's back up. Another word for parasympathetic is cholinergic. Another word for parasympathetic is cholinergic. Another word for parasympathetic is cholinergic, and you spell cholinergic with the first four letters C-H-O-L. Another word for parasympathetic is cholinergic, and cholinergic C-H-O-L. Most of the receptors in this parasympathetic cholinergic system are muscarinic receptors. These are your M receptors, your M1, your M2, your M3, your M4, and your M5. And once again, is for muscarinic in the parasympathetic cholinergic system. Now, M1, M3, and M5, the odd number ones are G-Q coupled. M2 and M4 are I coupled, okay? Are I coupled. Keep in mind also that these receptors are located throughout your body. So let's talk about where these receptors are located. What's the most important part of your body? The most important part of your body is your brain. What's the second most important part of your body? That's your heart. The third most important part of your body is your kidneys, okay? This is why when you get sick, it's like that rap song, right? You want to save your brain, you want to save your heart, you want to save your kidneys, but if you get sick, it's like that rap song, started from the bottom, now I'm here, kidneys go first. You got to save your brain, you got to save your heart. Your body will sacrifice your kidneys first. This is why a lot of patients are on ACE inhibitors or on dialysis or are given medications for kidney-related conditions, because when your body starts to go out, your kidneys end up going first. Now, I went through all that to make a simple point. The most important part of your body is your brain. Where do you think your M1 receptor is located? Your M1 receptor is located in the brain. So that's M for muscarinic, parasympathetic, cholinergic. M1 is in the brain. It's actually in the CNS, the central nervous system, and the ENS, or the enteric nervous system. M2 is in the heart. M2 is in the heart. So M1, muscarinic 1, is in the brain and in the ENS. M2 is in the heart. And when you stimulate that M2 receptor, it'll decrease your heart rate. Because remember, parasympathetic, rest and digest. So when we decrease heart rate via M2, we call that bradycardia. Now the M3 receptor is located everywhere else, and we'll get to how they're going to test you about this in a second, but let's review. M1 is in the brain and in the ENS, M2 is in the heart, M3 is everywhere else. So we talked about the M1 receptor, we talked about the M2 receptor. Let's talk now about the M3 receptor. The M3 receptor is the muscarinic type 3 receptor in the parasympathetic cholinergic system. Once again, cholinergic, C-H-O-L. Put that aside, we'll get to, Put that aside, we'll get to it later. Now I'm going to ask you a series of questions, and the answer every single time is going to be M3. So when you're watching this video, I want you to talk out loud, repeat things out loud. It'll help you learn the material. So the M3 receptor does several things. I'm going to ask you questions. The answer every single time is going to be M3. Which receptor can I stimulate to cause an increase in exocrine gland secretions? Which receptor can I stimulate to cause an increase in exocrine gland secretions? The answer is M3. M stands for muscarinic. Is that parasympathetic or sympathetic? It's parasympathetic. Is it cholinergic, anticholinergic? It's cholinergic. So now the M3 receptor has caused an increase in exocrine gland secretions. If I increase your exocrine gland secretions, are you going to be wet or dry? You're going to be wet. So far, M3 has made you wet. Who needs Tinder, right? Which receptor can I stimulate to cause an increase in gut motility? Which receptor can I stimulate to cause an increase in gut motility? That receptor is M3. M stands for muscarinic. Is that parasympathetic or sympathetic? It's parasympathetic. Is it cholinergic or anticholinergic? It's cholinergic. So far you're wet, and now you've increased gut motility. If I increase gut motility, are you pooping more or less? You're pooping more. So now the M3 receptor has made you wet and it's made you poop, right? And that's muscarinic type 3, parasympathetic, cholinergic. And this is why we give cholinergic drugs to patients who are constipated, because it increases gut motility. So far you're wet and you're pooping. Which receptor can I stimulate to cause bronchoconstriction? Which receptor can I stimulate to cause bronchoconstriction? M3, and M stands for muscarinic. Is that parasympathetic or sympathetic? It's parasympathetic. Is it cholinergic or anticholinergic? It's cholinergic. So far you're wet, you're pooping, and I just caused bronchoconstriction. Does that mean it's going to be harder or easier for you to breathe? it's going to be harder for you to breathe. So far M3 has made you wet, it's made you poop, and it's made it harder for you to breathe. Now, you thought that things couldn't get any worse because you're already not in very good shape with this receptor, but they're about to get worse because which receptor can I stimulate to cause bladder contraction? Which receptor can I stimulate to cause bladder contraction? M3. M stands for muscarinic. Is that parasympathetic or sympathetic? It's parasympathetic. Is it cholinergic or anticholinergic? It's cholinergic. So if I constrict or contract your bladder, are you peeing more or less? You're peeing more, okay? Repeat after me. M3 makes me pee. It even rhymes. So far you're peeing and you're pooping. Things are coming out of both ends. You're wet, right? A couple more things this receptor does. Which receptor can I stimulate to cause meiosis? M3. M stands for muscarinic. Is that parasympathetic or sympathetic? It's parasympathetic. Cholinergic or anticholinergic? It's cholinergic. It causes meiosis via the pupillary sphincter. What is meiosis? Is meiosis dilation of the pupil or constriction of your pupil? Meiosis is a smaller word. It causes constriction. Mydriasis with the D causes dilation. We're talking meiosis, which means it's causing constriction of your pupil via the pupillary sphincter. It can also cause accommodation via the ciliary muscle, and that receptor that causes accommodation is M3, and M stands for muscarinic, which is a part of the parasympathetic cholinergic system. So now this M3 receptor has made you wet, it's made you poop more, it's made it harder for you to breathe, it's made you pee, it's also caused accommodation and meiosis. Okay? This is all the M3 receptor, that muscarinic type 3 receptor, and the parasympathetic cholinergic system. So we talked about the muscarinic receptors. Let's now talk about the muscarinic medications. Before we do that, here's a quick little diagram that shows where muscarinic and nicotinic drugs work. Now, various drugs can target the acetylcholine receptor, which is what cholinergics do, right? Acetylcholine, cholinergic. So various drugs target the acetylcholine receptor on the presynaptic neuron. Some drugs work on the muscarinic type of the acetylcholine receptor, while some work on the nicotinic type of the acetylcholine receptor. The majority of drugs work directly on the receptor, while other drugs work indirectly on the receptor or the drug, such as increasing the concentration of acetylcholine in the synaptic cleft. And we'll talk about all those drugs in more detail, but here's a little overview diagram for you along with where these drugs work, and we'll get into those all individually in just a moment.